Jillian DiClemente. I'm a pain management clinical pharmacy specialist at Michigan Medicine in Ann Arbor, Michigan.
I'm Nate Menke. I'm the director of the Inpatient Addiction Medicine Consult Service at the University of Michigan.
I'm Hannah Kowalski. I'm the pharmacist for the Center for Inclusion Health Addiction Medicine Service.
Recovery seems very challenging, where your presentation, I think, highlighted that those with abstinence alone, for example, experience recovery rates of less than 50% at 6 months, less than 15% at 12 months. So from a physiologic perspective, what do you think makes these addiction circuits so strong that they're this hard to break or undo?
So unfortunately, the circuit that's being hijacked by these substances is what is used for the survival of both the individual and the species. So when that's hijacked, what is more important than survival? Well, it's these substances. And so you can imagine, what would you do to survive? And that's what the brain is telling you to do, to use these substances. And that's why it's so challenging. And then your whole brain gets rewired around these substances. So it's a terrible, terrible circuit that gets hijacked.
You highlight that addiction is a pathological form of learning where the brain becomes wired to seek these opioids at the expense of everything else, so work, family, etc. So it's possible for the brain to form these connections in the first place. Is it possible through recovery to rewire, undo these connections? What strength of an intervention do you have to reverse it?
That is absolutely possible. We see lots of patients that are able to get into recovery and stop using these substances. And that's why we use these medications. We use these medications to try and suppress that reward circuit that is responsible for survival. And then you also want to use counseling to strengthen their prefrontal cortex so that they have the skills to try and change their behaviors around their substance use. So we try and hit it from two different places, right? The reward circuit and the prefrontal cortex.
So the reward circuit is kind of like the primary intervention, and then counseling would be maintenance.
Right. So the data demonstrates that the best results get from methadone and buprenorphine by affecting the reward circuitry. And the CBT and the mutual health, or the mutual aid groups and that type of thing help the prefrontal cortex. So that is a good way of thinking about it, that until you get the reward center under control, that you can do all the counseling you want, but the brain is still focused on the substances.
The strength of intervention is going to be individualized to the patient also. And not only their willingness to participate in the non-pharmacologic side of recovery, but also the groups and engaging in resources and support systems that also aid in recovery.
Yeah. And finding a healthy support system and changing your day-to-day to be able to sustain recovery.
So how would you approach a patient that is amenable to sort of the primary intervention, but they're probably averse to the longer-term psychological side of recovery? Like, how would you approach them and maybe try to see if they can become amenable to that, since it is so integral to maintenance?
So one of our goals is to always meet the patient where they're at. So if a patient is not interested in counseling or that type of thing, we don't push it on them. So what we do is we provide information. So we say, these medications are first line and they work for a lot of patients, but sometimes it's not enough. So if you take these medications and it's not working, here are some other tools that you can use. Or we say, if you do want to come off these medicines, it's best that you have these tools, again, to help you prevent relapse. And so if you at any point want to come off, you should participate in these therapies because they help you learn how to change how you think and how you behave.
And it's not uncommon for us to see patients who are in that acute phase, like in acute withdrawal, and it's difficult for them to envision what
Down the road looks like.
Right, outside of the next 24 hours, what, the next week, 2 weeks, months, even a year might look like for them. And so I think that's really important that you highlight kind of addressing and being okay with where they're at in their recovery, getting through an acute phase, and then giving them the tools they need and access to those moving forward.
Yeah.
Knowing who to contact when that time comes, when they're ready.
Because you definitely take recovery one day at a time. It's daunting to look on and say, like, I will do this every day for 10 years. Like, it's hard to picture that, I think. So we always say, like, okay, take it a day at a time. How are you feeling today? And then we'll talk tomorrow again and go through. And I think our certified recovery specialists help a lot with that. They're employees that with lived experience that can help say, I was in your shoes once. I felt this way once, but let's get to tomorrow together. And then, keep taking steps together and see that it's possible to have other tools in the toolbox to help eventually.
Kind of building off that a little bit. You mentioned about 40% of these patients on recovering have a co-occurring psychiatric disorder. So I'm wondering if maybe you have some insight as to why this occurs. Are certain patients just predisposed to have these two issues simultaneously? Or are there perhaps social factors? Maybe it's easier to get illicit substances than it is proper mental health care.
So one causative factor for using substances is trauma. And so it makes your brain a lot more vulnerable to the effects of these substances. So anybody with trauma as a young child or as a teenager, even as an adult, puts you at risk for this, and it puts you at risk for psychiatric illness. So it just overlaps so much that it's very difficult to untie the two things. And like you said, a patient with untreated psychiatric illness, you can find treatment on the street, and it may not work well, but your brain will tell you are feeling better at that moment. So it is definitely a possibility that some patients are self-treating with these non-prescribed substances.
And I feel like in active addiction, it's very hard to tell what comes from like the drug and then what comes from a psychiatric illness, and like diagnosing the two and being able to tease that out can be very difficult, I feel like, to get the right one and be able to treat both.
I had a follow-up question. If it was the latter, if it was easier to obtain illicit opioids rather than mental health care, how could we address this to prevent it going forward if it's possible? Is it possible to be better stewards of mental health as a means to mitigate the opioid epidemic?
I mean, so at our institution, there's a very long wait list to be able to see psychiatry, and that's true for a lot of institutions around the country. We just do not provide adequate mental health resources for Americans. And that's a systemic issue, and you would have to just change how we do medicine in this country. And I'm not sure how feasible that is, but it would be helpful.
Yeah, it's definitely an access issue for sure.
And substance use disorder spans all people, all incomes.
No discrimination.
Yeah, there's no discrimination. And I think that's also important to highlight is if you make mental health care and resources more affordable, will that change? Will that change the landscape?
Because if you're, based on your resources that you have, your treatment can be vastly different and available. Income-wise and insurance-wise and things like that changes the game for a lot of people.
You mentioned that there's a wait list for psychiatric care at your institutions. I think I read something where there is almost a shortage of PCPs, that they were trying to get incoming med students to kind of commit to that specialty so that there wasn't going to be this deficit of PCPs that are sort of the first line. Is this wait list due to maybe a lack of the volume of people who are in psychiatry? Is there a deficit there as well? Or is it just that what we have at our disposal isn't enough to meet maybe a growing demand?
Yeah, I think it's a combination. Like, there's definitely not enough psychiatrists, and just like PCPs, that goal to get more PCPs, that's been around since when I was in med school. So that is not new. And again, when you don't pay providers to do the care they want to do, then you can't recruit people to this field. Like, no one wants to work a ton of hours and not get paid much and not feel like they're providing good care for patients because they have 15 minutes for a visit and can't address a patient's issues. So how do you make people go into a field when they're going to live a poor lifestyle and not be able to take care of patients like they want? So, I mean, it's an issue with our healthcare system that physicians that are primary cares are not reimbursed like a GI specialist who's just doing procedures. And it's just how we pay providers.
And I think for PCP, just from like my experience, like with PCP, like I feel like a lot rides on them to take care of. Like you're not only addressing everyday things like diabetes, like hypertension, things like that, but then to throw mental health on top of that in 15 minutes, I don't know how you would address it and do an assessment. Like to me, it just doesn't seem like it's like feasible.